tuyến giáp và chức năng tim mạch như thế nào? Xin được giới thiệu giáo sư Peter Singer, mà giáo sư của khoa y lâm sàng, tức là Professor of Clinical Medicine, Chief of Clinical Endocrinology, Emeritus, Keck School of Medicine, University of Southern California, Los Angeles, United States. And now I would like to introduce Professor Peter Singer from United States, Professor of Clinical Medicine, Chief Clinical Endocrinology, Emeritus, Keck School of Medicine, University of Southern California, Los Angeles, and topic about the problem of heart disease in thyroid disease. Answer. I would like to introduce Professor Peter.
Hello. My name is Peter Singer from the University of Southern California, and I want to thank Dr. Tak Nguyen and the organizers of this conference for inviting me to speak. My topic is the effects of thyroid hormone on cardiovascular function and how it affects clinical disorders of the thyroid. So here's the issues of thyroid hormone. That's one of the topics. The next thing is, what are the clinical effects of both hyper and hypothyroidism on cardiovascular function? And finally, how do we treat patients with thyroid disorders as they affect the heart? Now, first, this is a complicated slide, but I want to go through it I want to discuss the sites of action of thyroid hormone on the heart. As you know, the thyroid gland secretes both thyroxine and triiodothyronine. T4, or thyroxine, goes to the liver where it's converted to T3. Now, T3 is the metabolic endpoint of thyroid hormone. Well, how does it affect the heart? T3, as you know, affects tissue thermogenesis, but in terms of the heart, it decreases systemic vascular resistance and diastolic blood pressure. It amplifies the renin-angiotensin-aldosterone system, and as a matter of fact, then will affect preload. This is normal function, by the way, and affects thyroid muscle function as well as heart rate, which leads to effects on cardiac output. Now, I want to present some cases. The first case is a 66-year-old man who got short of breath when he was running. He went to the emergency room and he was found to be in AFib. He also said he lost about 15 kilograms in the prior 3 months. His physical exam showed that he had AFib. His thyroid gland was a little bit enlarged, and he had a tremor of the outstretched hands. And here how he looked. He doesn't look that good, does he? It looks like he's lost weight. And he said he lost about 15 kilos. Here's just a tracing of his AFib. Okay, here's his labs. The important ones showed that he had an elevated free T4, the upper limit is 1.8, and a suppressed TSH, and an elevated radioactive ion uptake. So he had Graves' disease. Next case, 74-year-old woman, new onset AFib, no prior cardiac history, no thyroid history, no real symptoms of hyperthyroidism. She was thin, appeared somewhat apathetic, and here, irregular AFib. Her gland was a little bit enlarged. Now, the important issue here is that she had a normal free T4, upper limit 2.0, hers is 1.6, and a suppressed TSH. She also had a normal total T3. So she had what's called subclinical hyperthyroidism, normal T4 and T3, and suppressed TSH. This is her picture. Okay. Well, how does hyperthyroidism affect cardiac hemodynamics? Again, we have here an elevated T3. Recall that T3 is the metabolic endpoint of thyroid hormone. The T3 increases tissue thermogenesis, decreases systemic vascular volume and effective vascular volume, increase renal absorption of sodium, which leads to an increased blood volume. She has increased heart rate and force of muscle contraction, and in hyperthyroidism, an increased cardiac output. So a patient with Graves' disease, rather than a cardiac volume, a blood volume of 5 liters, may have a blood volume of 7 liters for that matter. Okay, and in addition, in hyperthyroidism, you have an increased beta adrenergic response leading to an increased heart rate and cardiac output. Okay, now it's interesting that case 1, Graves' disease, case 2, subclinical hyperthyroidism, both of them have an increase in atrial fib. These are in older people, by the way, compared to controls. So both subclinical hyperthyroidism, case 2, and case 1, both are associated with AFib. Now, here shows the over a 10-year period of developing AFib according to the TSH. So this is years, and this is TSH, the frequency of AFib according to the serum TSH. And here, after 10 years of having a low TSH, about 30% of people, and these were individuals over 60 years of age, developed AFib. So the longer the TSH is suppressed, the longer it's low, the greater the likelihood of AFib. So the most common cardiac complication of thyrotoxicosis, hyperthyroidism, is AFib. Moreover, 8% of new diagnoses of hyperthyroidism, new patients, develop AFib within 30 days. And as you know, here's the complications of atrial fibrillation, embolism, CHF, and cardiomyopathy, things that all you know as cardiologists. Well, what are the risk factors for AFib? The older you are, male gender, a history of cardiovascular disease. So those with coronary artery disease, failure, valvular heart disease, all are risk factors for developing atrial fibrillation in the face of having either overt hyperthyroidism or subclinical hyperthyroidism. Okay, so how do you manage it? It's interesting that don't cardiovert right away, because 2/3 of patients will revert to normal sinus within a couple of months after becoming euthyroid. So cardioversion will fail while hyperthyroid. So at our university, we wait, we treat the thyroid, and we usually wait about 3 months of patients being euthyroid before we send them for cardioversion. In the meantime, these patients, as you know, are treated medically. Okay, so where are we? Case 3, we're going the other side. A 50-year-old man, 54, increasing fatigue, felt cold, no history of cardiac disease. His exam, bradycardia, as you can see here. Skin was cool, the heart tones were distant, so he had profound hypothyroidism, significantly elevated TSH, as you can see here. Free T4 was very, very low, and he had positive antibodies, so he had Hashimoto's thyroiditis. Very, very significant hypo. And here he is. Look at the puffiness around his eyes. This is a ruddy complexion that you sometimes see with significant hypothyroidism. Well, this slide looks familiar, doesn't it? It looks like the slide on hyper, but I'm substituting hypo on cardiovascular dynamics. So with these patients, decreased tissue heat production, increased SVR, increased effective plasma volume, and the point is that in these patients have a decreased blood volume because of an increased systemic vascular resistance, decreased inotropy and chronotropy, so decreased force of contraction, decreased heart rate, and decreased cardiac output. Now, the other thing is, in contrast to hyper, these patients have a reduced beta adrenergic response. So what are the cardiovascular changes we see with hypo? Apparent cardiomegaly, well, that's just apparent. EKG changes, the bradycardia, decreased myocardial contractility, and increased diastolic pressure and systemic vascular resistance. The other things that we see with hypothyroidism is cholesterol levels increase with increasing TSH. TSH is measured here. The higher the TSH, the greater the increase in cholesterol, which over time obviously can affect coronary artery disease. Okay, and this is just an EKG of that patient, low voltage bradycardia. This basically is from a pericardial effusion, which is the reason that he has decreased heart tones. Okay, case 3, we began full replacement with thyroxine, 1.6 micrograms. He had no history, by the way. He had no history of cardiac disease. And a couple weeks later, he developed chest pain. So he saw a cardiologist, he had coronary disease, and a stent was placed in his left anterior descending artery. If we knew he had cardiac disease to begin with, you treat the coronary artery disease, put a stent in before beginning thyroxine. In general, patients with underlying coronary artery disease, we treat with thyroxine if they have known disease very slow. Low levels of T4 gradually increase every 2 months or so, and the endpoint is a normal TSH. Last case, 76-year-old woman started becoming forgetful, not as forgetful as me probably. She had a mildly elevated TSH, but a normal free T4, as you can see here, 1.1, and this is the normal reference range. She had subclinical hypothyroidism, normal T4, elevated TSH. So the question, would her disorder lead to cardiac complications? And the second question for her is there benefit of giving her thyroxine? This is her. Okay. This study was done in Rotterdam about 20 years ago, and it showed these were all women. A mean age was 69 of 1,100 women, euthyroid versus subclinical. Those patients with subclinical had a greater likelihood of having an MI and atherosclerosis. Not only that, if they were hypothyroid due to Hashimoto's, this amplified the likelihood of developing coronary artery disease or MI. So the question is, should all patients with subclinical hypo be treated? Now, most of them are asymptomatic, but the question is, should they be treated? This was a study. It's very hard to look at all these data. It'll be shown on your, you can all have a collection of these slides. These were patients older than 65, 10-year follow-up, not on thyroid hormone. And what was noted over the 10-year period of time, there was no increase in coronary heart disease, no increase in these patients of heart failure, and no increase in cardiovascular death. So these patients, the conclusion here, with a subclinical, in other words, a TSH of 6, 7, 8, normal T4 in these older patients over 10-year follow-up, they didn't have an increase in cardiovascular events. Now, what about cardiovascular events in younger people? So, and it's again hard to read, these are individuals 40 years to 70 years who did not get treated with thyroxine. These are patients who were treated with thyroxine. Well, what happened? The younger patients untreated had more cardiac events. Look down here. These are patients older than 70, like our 76-year-old patient. The patients who were untreated, here, had fewer cardiac events than patients who were treated. Okay, so the conclusion was, if you have a patient greater than 70 with subclinical hypothyroidism, it probably isn't necessary to treat these patients. So, what is the summary of thyroid status and cardiovascular events? Overt, like our patient, 54-year-old patient, and some patients with subclinical overt hypothyroidism, like our first patient, and subclinical, like our second patient, do have adverse effects. Overt hypo, like our 54-year-old patient, also has adverse cardiovascular effects. But the treatment of old patients, old being anyone a month older than me, with subclinical hypothyroidism, in other words, a TSH less than 10, treating those has negative effects. Now, I just want to spend 1 minute and discuss my personal cardiac experience with our foundation, East meets West, Domte Hoignal. So in our organization, East meets West, we had a heart program over 20 years. We stopped it in 2014. We treated here in Vietnam over 2,600 kids with congenital heart disease. Okay? And we were fortunate to be able, with donations and our foundation, to build a cardiovascular center in Hue. And this was the dedication of our cardiovascular center in March 2007. And I give thanks to my friend, Bui Duc Phu, who was the chief surgeon, and Phu has now retired and moved to Hanoi, although his son is at Hue, in Hue Central Hospital, doing surgery. So this is Phu and me in 2008, shortly after the dedication of our cardiovascular center. And in my last visit 3 years ago, unfortunately, COVID keeps me away these days. The Hue Cardiovascular Center, I'm happy to say, is still functioning very well after all these years. So I thank you for the opportunity to speak at this conference. Unfortunately, I'm not going to be available to answer direct questions because in looking at the schedule, it's going to be in the middle of the night for me when my talk comes up, although maybe I'll set the alarm clock and get up and do it directly. Again, thank you very much. Bye-bye.
Thank you. Thank you. Anyway, your presentation very interesting and useful. I agree with you that with hyper thyroid, even with the subclinical, we should focus in treatment. For example, the complication of the atrial fibrillation, many causes. Among that, there is the problem of hypothyroidism. But hypothyroidism, overt hypothyroidism, we should treat the dyslipidemia. But with the subclinical hypothyroidism, we focus in the age. I agree with you. With older, we is in the usefulness of the treatment. Thank you so much. Xin cảm ơn ông rất nhiều. Có thể nói rằng là tình hình rất là khó khăn nhưng mà ông vẫn giúp đỡ. and the program of Đông Tây Hội Ngộ, we can say that on behalf of the children in our city, thank you so much for your help last time. And we will inform your information today with the Professor Phú. Thank you so much and goodbye. And now Professor Thủy.
Thank you very much, Dr. Peter Singer, for your interesting presentation. I have a question with you.